So should we make a start? Yeah, that's right. That's okay. That's sure. Yeah, good idea. So Jem is my name, eczema nurse practitioner at Perth Children's Hospital, and Darren and I will be presenting this session today on eczema in children. And really, we want to make it an interactive session. We want it to be helpful for you. We don't want to stand here and just present a whole series of slides. So it'd be really great, just before we start, to talk about, or to just find out, who is comfortable seeing children with eczema? Hands up. Who's really comfortable seeing children with eczema? Great. Yep, so a few people. And for those, I guess what would be also really helpful to understand is what are some of the barriers and challenges that you face in your clinical practice when treating children with eczema, or even adults, for those of you who don't see many children, because a lot of the principles are actually the same. And hopefully today in this afternoon session we can talk about some of those barriers and challenges and help you be able to take some practical tips back to your workplaces. So is anyone willing to share what some of the barriers and challenges are? I've always got lots. Parents? Yeah, so what's challenging about parents of children with eczema? Yep, so that's a great point. So the point was that parents sometimes, in fact, often will come with they want to try lots of different things, have been told lots of different things, there's lots of conflicting information, lots of misinformation, and so often these families have got very complicated regimes and that can make treatment really hard. Yep, that's a great challenge. And you're absolutely right. I think keeping eczema really simple is where you get great results. The minute you start to complicate things, it's very hard to sustain. They'll be great for the first 2 or 3 or 4 weeks, and then sustaining it is the tricky bit. Any other barriers and challenges? Yeah. Yes. Yep, children with sensory issues who don't like certain creams and ointments. Yeah, very tricky. So what do you do in your workplace, in your clinics to manage that? Yes, yeah, it's a juggle, isn't it? Yeah, using the creams that are least likely to sting, but sometimes that can be tricky because if these children have got lots of excoriation, then you apply a cream because they don't like the greasy feeling of an ointment, but the creams have got preservatives in, so they're likely to sting. Really tricky, yeah. Very, very tricky. And any challenges down the back? Was there one final? It's gone. It might come back. If it comes back, just let me know. So some of the things I thought we'd just touch on today are just a systematic approach. We'll just touch on this because I have printed out the notes for you. But sometimes having, for the more simple rashes, it's fine. It's not, you don't need it as much. But especially when we get these complicated rashes coming in, having a nice systematic approach to describing rashes can be really helpful. One of the most common questions we get in clinic is, what is eczema and what's caused it? Was it that I accidentally gave some cow's milk at 6 months old and that's now brought on the eczema? So yesterday afternoon when I was attending the eczema workshop yesterday, I had a call from a family. Mum rang and said the baby's now 7 months old, and she said it's the second baby and oh gosh, it's my fault because the eczema's come on since I gave a little bit of cow's milk in the pumpkin mash, which happened at around 6 months of age. And so it's really tricky, most babies will start to get eczema in the first year of life, and many will develop eczema in the first 3 to 6 months. So a lot of things are happening around that time, introducing solids, introducing allergenic foods, viral illnesses, vaccinations, a whole heap of things. So parents can very easily come to the conclusion of, oh gosh, my baby's got eczema and a cow's milk allergy. So there's a lot of things that you often need to tease out in these eczema clinics, and we'll touch on some of these today. We'll talk about eczema in different skin types. So I don't know about you, but our eczema clinic we're seeing a lot of different ethnic groups, a lot of skin and colour, and some of those rashes can be quite tricky to treat and to diagnose. For those people who have just come in, feel free to get yourself some questions, pre and post questions, and some summary notes because they'll have some of the information from the slides today. We'll talk about some first-line treatments for eczema in children. I'm not going to talk too much about the systemic agents. We're going to focus mainly on the topical treatments, plus and minus wet dressings, bleach baths. We'll talk about how to choose suitable skin products. We'll talk about some of the new eczema resources. And I've included lots of case studies to keep it nice and interactive. And please ask questions at any time. No need to wait to the end. So has everyone had a chance to just complete the self-knowledge pre-workshop questions? Does anyone need a minute or so longer to do that? Yeah, sure, that's fine. Take a minute or so to complete that. So we're going to move on now. So if you haven't had a chance to complete those questions, feel free to keep filling them out. And we will, towards the end, we'll have another chance to go through those questions and you can ask any questions you'd like about them. So when we talk about describing rashes, it's really helpful to find out when it started, how it's progressed. So did it start on the face and it's now progressed to torso and limbs? And also, has the baby been well? In so many cases, parents will say, I had the eczema really well controlled and now it's just gone crazy. It's flared, I don't know why. And then almost always, if you ask, in the last month or in the last few weeks, has the baby been unwell? Have they had any vaccinations? Sure enough, oh yes, they had a vaccine 2 weeks ago. So anything that activates the immune system can flare eczema. So really helpful to ask, what else has been going on. And how has it progressed? Is it getting better? Is it getting worse? And what makes it worse? So, when she goes swimming, the eczema flares, or, when he plays sport, his eczema flares. So they're really helpful things that are going to help with your eczema management, your eczema treatment. Is it stinging? Is it burning? What have they tried? So what have they tried in the past? What's worked? What hasn't? Who have they seen? Some of our families will come in, they've seen, in many cases, a lot of these families have seen multiple clinicians. They've seen multiple GPs for their eczema, and in some cases, even 2 or 3 dermatologists as well. So really helpful to find out what's worked, what hasn't, and if they've been prescribed something that you think should have worked, because this happens a lot, it's really helpful to ask, well, where have they been applying it? How long have they been using it for? When do they stop it and when do they start? And we'll talk about some of that when we talk about prescribing topical steroids. How many people in the room do actually prescribe topical treatments for eczema? Yeah, a few. Okay, great. So, and also asking about, do they have a family history of allergic disease? Are there any first-degree relatives with a history of eczema, food allergy, asthma or hay fever, because that's going to help in your diagnosis of atopic dermatitis. Also asking about pets, have they travelled recently, and always really helpful to ask about alternative treatments. A lot of these families are desperate to find a cure, and so they do a lot of reading on Dr. Google. So really helpful or really important to find out what else they might be using. And why do you think it is so important to ask about medicine or about natural treatments? Because what? A lot of people do try natural treatments. Yep. And what do natural treatments have in them that might be a problem for eczema? So they've often got a lot of plant extracts and a lot of food proteins, and we'll talk about why we don't want to use food proteins on the skin of children with eczema. And so we're also looking for pattern of distribution. You know, is there a purpuric rash from the waist down? Well, yep, that's going to give you clues about what else it could be. So really important to look at hair, nails and the pattern of distribution of this rash. So for example, I just had a family who asked to come and see me in my private clinic for this girl who is living interstate who's got an itchy rash on the inside of the inner aspect of her feet. She's an infant, so automatically that makes you think this is really odd. That pattern of distribution just isn't fitting with a typical picture. And also in my assessment, I always find it really helpful to write, you know, if there are some key negatives like no excoriation, no lichenification, no signs of secondary skin infection, that can be really helpful in your clinical history as well. Some of you might have come across this, but this can be a really nice way to help describe rashes. This is in your notes. So again, you know, that pattern of distribution is helpful. The erythema, now that we're seeing so many children with skin of colour, we need to be mindful that erythema in skin of colour can often be seen as grey or even violaceous. And so that's really important when we're using our eczema severity scores, particularly EASY score. The other thing too, this can trip a lot of people up. A lot of children who are referred to our eczema clinic have been given a diagnosis of a fungal infection in the past. They've tried an antifungal and it's not helped. So hindsight is a good thing, but some of the key sort of hints in your history, if you like, and what the rash looks like. So if you've got some central pallor and some scaling around the edge, that, you know, sometimes people will think that's discoid eczema because of you've got the annular ring, but in actual fact, you know, that's more likely to be fungal. So looking for your central pallor and some clues like that can be really helpful. This, in terms of type and morphology, that can also be really helpful to, especially because when it comes to contact irritation, you know, when children have got eczema, they've, say for example, eaten some tomato or something that's caused some contact irritation on their skin, and sometimes people might think that's an allergy. So really helpful to ask about hives, etc., where there are additional signs like that. We've already talked about the colour. Arrangement that could be really helpful. So if someone was, you know, handing a patient over to you over the phone and described these clustered pearly dome papules, then that automatically would make me think, that's not sounding like eczema. Could it be something like molluscum? And, you know, another thing that's referred often to our clinic is keratosis pilaris. You know, a lot of GPs will refer in saying, you know, we've tried a fairly potent topical steroid and this redness is just not going away. So if you look at the pattern of distribution, you've got these bumps on the skin, the hyperkeratotic papules that are not responding to topical steroid. If they're on the sides of the cheeks, the backs of the upper arms, sometimes the thighs, then you'd be thinking, is this keratosis pilaris rather than atopic dermatitis? So all these things can start to paint a nice history and a nice picture. The border we talked about, and also special sites, you know, are special sites involved. So I won't go too much more into that. I have printed it out for you, but a nice this acronym can be really helpful, especially when you've got tricky rashes. Sometimes I'll get referrals to me in eczema clinic that actually are clearly not eczema, but it's really helpful when I have to present to the dermatologist this rash that I don't know what it is, but it's really helpful if you can kind of include some of those key findings in your history. And I think a good clinical history is really, really important. So I find, you know, these parents often come in, they've got so many worries, they've been told so many different things by many different people, and it's really helpful just at the start of the clinic to ask them what is worrying you about your eczema or your child's eczema. And then you'll pick up lots of things about, you know, whether steroids the worry, or whether infection, or what, you know, whether, you know, they don't want to go swimming because of how their skin looks, whatever it might be. And helping them understand about their eczema, you know, it's quite helpful to work out and to learn what do they understand about eczema and what they've been told about topical steroids, because again, that can really help guide your discussion in clinic. I always ask them about their treatment goals because my treatment goals might be very different to their treatment goals, especially for some of our teens. You know, I aim for complete clearance. We're really fussy in eczema clinic. No eczema is okay. But for some of these teens, you know, a little bit of eczema is, if they can manage to clear most of their eczema and have a little bit of eczema, then that's really good according to that particular person. Or, it might be that, just helping them get enough sleep to be able to go to school to attend maths on that particular day, whatever it might be. Often asking them when it started, because like I said, for most children, eczema will start in the first 12 months of life, and for many within sort of the first 3 to 6 months of life. We've talked about who have they seen for eczema, who have they seen, what have they tried, what's worked. And then I'll ask them about what are they currently using. So are they having a bath or shower? We'll ask them about the temperature, how long they're in for. Often the school age and teens like to have a long hot shower. So encourage them and help them with strategies to make sure that we're sort of helping them to come up with ways to make sure to have a shorter shower, not too hot. Using moisturiser, it's really important to ask how much, where and how often, because a lot of them will say, if you're just saying using QV cream, don't assume that they're using QV cream twice daily to the whole body, because in many situations they might just be applying a moisturising cream to the affected areas on some days. So really helpful to ask about, to delve in a little bit more about the moisturiser. And also, I always ask them, are you happy using the moisturiser that you're using? Because sometimes I'll go and see someone who says, oh, yep, use Dermese ointment or use a particular ointment. They say, I hate it. So let's help them find something that's cosmetically acceptable to them, because they're more likely to use it long term. Topical steroid. So this usually creates a lot of discussion in clinic, but really important to ask them when they've last used it, where they've applied it, how much they've used in the last month, or how long does one 15-gram tube last them. Because sometimes they've been prescribed the right treatment, but they're just not using it properly. So they say, oh, yep, I've been to see the dermatologist and I've been prescribed this, and it just doesn't work. And you're thinking, gee, that's a topical steroid that really should work for the eczema that I'm seeing. So just making sure that they are applying it liberally to all affected areas, etc. And we'll talk a little bit more about the topical steroids. But that's really helpful to tease out. I always ask about sleep and itch, because that's really important. That affects quality of life for all ages. Also helpful to ask what makes eczema worse. Any known triggers? For many families, there are no known triggers, and that's okay. My kids have got eczema and I don't know what triggers their eczema either. So rather than families focusing so much on what triggers the eczema, we worry about fixing, clearing the eczema. So next week we've got them clear and we're not talking about eczema. So I try and help them. There might be some things where, viral illnesses have triggered it, or teething, or sweat, particularly after playing sport. But in many cases, we don't know the exact trigger of. In fact, there is no single trigger for every eczema flare. Skin infections. These children with eczema are covered with staph. They're colonised with Staph aureus, so they're very prone to skin infections and are more likely to end up on antibiotics, although we do try really hard not to prescribe antibiotics if we don't have to. But it is helpful to ask if they've got a history of skin infections, and why might that be? Why would we want to ask a child with eczema whether they've got a history of skin infections? Any suggestions? Because that's going to be one of the things that will help us work out whether we might need to think about something like bleach baths, or ask them, do they go swimming in their local pool? Because that's very similar to having a bleach bath, and we'll talk a little bit more about bleach baths. And also it can be really helpful if this child gets folliculitis, recurring folliculitis, and then you've got lots of family members who have also got a history of folliculitis, or lots of pimples, pustules, etc., then you might need to think about staph decolonisation for the family, for the individual and the family, rather than just the child who's in front of you. Also really helpful to ask about diet, because a lot of these families restrict diet because of whatever they've read on the internet, or a health professional has suggested, or a friend has suggested they exclude wheat, dairy, etc. But really important not to exclude exclude food from the diet, and we'll talk a little bit more about that later on, and also about the family history of ATP. So in all my eczema assessments, this is what I would include. So does anyone have any questions so far before we just touch on the pathophysiology? And we're going to get to some case studies in a minute, so it's not all this dry. But I will just quickly talk about the pathophysiology of eczema, because one of the most common questions I get asked is, what causes eczema? Why has my baby got eczema anyway? Is it something I've done? Is it something that we've done in pregnancy? So it's a complex and very multifactorial disease. So there are a lot of factors, but the main factors are genetic, environmental, this immune system dysfunction and this altered skin barrier. So genetic, we know that these children who have got a first-degree relative with a history of allergic disease have got, their child is more likely to develop eczema. Environmental, we're definitely seeing lots more children who are born in Australia to parents who are born overseas, and they've got much trickier eczema. They've certainly got more allergic disease and more moderate to severe eczema. It's harder to treat. We know these children, they've got this hyper-responsive immune system. The immune system wants to react to things that are usually harmless in the environment. So things like animal dander, house dust mite, pollen, etc. And then they've got this altered skin barrier where the outer layer of the skin doesn't work properly. It's like a leaky skin barrier. And a really helpful analogy for those of you, some of you I'm sure already use the analogy of the brick wall, but it's really helpful. I find analogies in eczema just work really, really well, especially eczema in children. So I often will explain to families that children with eczema, it's basically the outer layer of their skin is like a brick wall where the bricklayers haven't done a very good job. There's lots of gaps and cracks between the skin cells, the corneocytes, and not enough glue, not enough mortar, so not enough lipids and natural moisturising factors to block those gaps between the bricks. Okay, between the skin cells. So moisture leaks out and irritants and allergens come into the body more easily through that altered skin barrier and can cause inflammation. And that's also one of the reasons why we don't want to apply skin products with food containing proteins on the skin to these children, particularly at any time, but particularly if they haven't yet eaten the food. Because when you put food proteins on the skin of these children before they've eaten it, you're likely to promote allergy. When they eat the food and it goes into the gut, you're likely to promote oral tolerance. So really important, because a lot of these skin products do say endorsed by Eczema Association of Australasia, etc. So and that really frustrates parents, because a lot of them are natural and do contain these food proteins. So just watch out for the oats, the colloidal oatmeal, macadamia oil, sweet almond oil, and some of the others. So these are just some pictures of eczema that show, regardless of where the eczema is, how old the child is, a lot of the principles are still exactly the same for treating eczema. So the first thing is to treat the skin, and our allergy specialists and dermatologists are always teaching that eczema is a barrier issue, not an allergy issue. So we fix the skin, and if the eczema is still really tricky to control, then we think about what else could be driving it. And I think for us, our paediatric dermatologists are always encouraging us. The message that they give every day in clinic to these families and to everyone who they teach about eczema is treat eczema aggressively early. So often what happens for these children is you've got a little 5-month-old baby with a bit of mild eczema, and they're often told, don't worry about that, just apply moisturiser and it'll probably go away. But actually, the evidence tells us that if you manage eczema properly in these infants, then with a topical steroid, with the right topical steroid, then they're less likely to develop a food allergy by 12 months of age. So really important to treat eczema aggressively early. So when we talk about optimising eczema, we actually talk about 2 types of treatments. We talk about the daily general measures, and then we talk about the flaring treatments. So for the daily general measures, they're things that we want to encourage our families to do every single day till their children have left home. And when I say every single day, we want to aim for most days each week. So aim for a daily bath or shower in the evening at the end of the day to wash all the sweat, the irritants, the allergens, the food proteins, etc. off. So really big emphasis on letting these kids be normal kids during the day, and then at the end of every day after dinner we give them a bath or shower. We want to make sure, as you guys know, you want to avoid soap and bubble bath because they're very drying and irritating for the skin and can interfere with, or basically make the altered skin barrier worse, that you're not maintaining and improving that skin barrier. We want to make sure that it's on the cooler side of warm and using a bath oil, a dispersible bath oil, or a soap-free wash. Getting out of the bath, patting the skin dry, and then apply, if they didn't have any eczema, then you would just want to apply moisturiser to the whole body. So applying moisturiser to the whole body, and we'll talk about how to choose a suitable moisturiser in a minute, and then they would put jammies on and into bed. If they had eczema, you'd hop out of the bath or shower, pat the skin dry, apply the topical steroid to all eczema-affected areas, not just the worst bits, and including areas of broken skin. And then you would apply the moisturiser everywhere else over the body. If you look at therapeutic guidelines, it tells us to apply the steroid after the shower and then apply moisturiser everywhere else on the body. But if, as you know, some of these babies, when they come in with widespread eczema, it's just easier to put moisturiser head to toe, and they still come back next week completely clear. So it does still work, and I say to families, you don't need to wait between the steroid and the moisturiser, and it's okay if a bit of moisturiser goes onto the steroid. So bath or shower, followed by the topical steroid or topical calcineurin inhibitor, and then followed by moisturiser, jammies on, and they're ready for bed. In the literature, you will see all sorts of different things written about, delaying the topical steroid and the moisturiser, but practically what can happen with that is if you wait, if you wait and you apply moisturiser and then think, I'll go back, in 20 minutes when the moisturiser's all absorbed and apply the topical steroid, usually everyone's too tired, child's gone to bed, and you've missed that boat. So we do risk them not being able to apply the topical steroid, and then they'll miss it for that day. Why do you think we've got flare control cream written in red here next to the topical steroid? Any suggestions? People are scared of steroids, yeah. And Darren actually has got some colleagues, she's been working really closely with colleagues internationally who are now moving away from the term topical steroid and using sort of the more flare control cream basically when they're talking about topical steroids. But I'd stay, I'm still really honest with families and talk about topical steroids, because if we don't unpick their worry about topical steroids, we are never going to win with their eczema. They're just going to have this burden and this worry hanging over their head, and you can explain all you like and you can give them a treatment plan, but they're not going to follow it. So it's really, really important. That's why I do long consults for these new referrals, because it's really helpful to unpick some of those cultural barriers or what they've heard, what they've read, what they've been told. So the important thing is we would use our topical steroid every day until the skin feels smooth, rather than a certain number of days. So a lot of these families have been told to only use their topical steroid for 3 days, 5 days, a week, 14 days, whatever they've been told, all sorts of different things. But the worry with that is they might have been told to use it for 5 days, but might have just needed to continue for another 2 or 3 days before they stopped. So then they end up partially treating the eczema, and within a few days it comes back. And then families will say, oh, my child's got steroid withdrawal syndrome, or they're now addicted to steroids. But when you explain the pathophysiology and explain it like a fire, if you explain it in a way that they understand, so you can kind of help them by saying, so you've applied your topical steroid, you've tried to put out a bushfire with a garden hose. You've used your topical steroid for a few days until the redness settled, but when you stopped the steroid, did the skin feel completely smooth? And they say, oh no, it did actually feel, no, it was still rough. And so that's the key. So don't stop the steroid when the redness settles. You need to keep going with the steroid until the skin feels smooth. And for most of these babies with acute eczema, that'll be within a few days, up to, a week, 7 to 10 days. Almost all of them are clear after 2 weeks. And then for our children with more chronic eczema, we give them 4 to 6 weeks. So that's why it's really helpful not to give them a certain number of days, but I do say to these children with acute eczema that for most children, your eczema is going to be clear within 2 weeks. And if it's not, you need to let me know. And if it's not clearing with the right topical steroid, then you need to be thinking, there are 4 things. What could it be, do you think? In every single case that comes through to us, there are usually 4 reasons why the eczema's not better. What could one of them be? Moisturising? Yep, so you are right. If you're using a moisturiser every day, then that's going to improve and maintain the skin barrier and acts as a steroid-sparing effect. So you're going to end up using less steroid in the long term, so yes. Yep, exactly. Applying it sparingly to the worst areas, so we're not using enough steroid. So yep, not using enough steroid. Not using the right steroid. We're using an over-the-counter topical steroid when we need to be using a more potent steroid. And a lot of people are quite afraid of using a potent topical steroid in a child, but don't be, because you've got this. If you use it, apply it liberally and properly, next week their eczema's clear. So rather than using a mild over-the-counter topical steroid for weeks and weeks, you finally clear them, if you're lucky to clear them with that, and then they get a cold, so they've stopped it for a couple of days, they get a cold, and then you're off using it for another month. So you end up using topical steroid on most days each week doing that, so you're better off getting the helicopter in, water bombing the fire, clearing the eczema, stopping the steroid. And that's appropriate use of topical steroid. So where you come unstuck is when it's all this inappropriate use of steroid. You use it for 3 days, you stop for 2, then you use it for another week, you stop for a day. You know, this intermittent kind of inappropriate use is where you're going to get problems, perioral dermatitis and things like that. So yes, we're not using enough steroid, or we haven't prescribed the right steroid, or is there any underlying infection? Because in so many cases you think, this eczema should be clearing, and sure enough you prescribe a course of antibiotics or start some bleach bars and it clears. So yep, think of infection. And then the other thing is differential diagnosis. Is this eczema? So after working in emergency for almost 20 years, I used to get really nervous, so I went from paediatric emergency and set up my own paediatric eczema clinic while I was waiting for a position to become available in our hospital. And I was so nervous about what happens if I miss this child who doesn't have eczema. What happens if I prescribe a topical steroid for a child that I thought was eczema and it's not? And the dermatologist used to always reassure me by saying, don't worry, because if the rash is not improving within 2 weeks and it's not eczema. And so that kind of made me feel better, but it was, for a while I was very nervous that I'd miss. But yes, they're right. If there's no significant improvement within 2 weeks of an appropriate topical steroid, you would be thinking about what else could this be? Could it be fungal? Could it be something else? So any questions about these daily general measures and the flaring measures? We'll talk a little bit more about topical steroids in a minute. But any questions about... Yes, Darren. Yeah, well, sometimes parents say to me, I don't know, what are you using? What did I buy you? What's in the shower? So, yeah. Yeah, and sometimes what I do for the teens is I tell them to put a timer on in the shower because they don't, it's very hard for them to remember what's too long. So sometimes using a timer can be helpful. And I've really just popped this slide in to remind us that actually we want these kids to be normal, happy, healthy kids playing outside, getting dirty and eating a wide variety of, that diet diversity is really important. Yeah, that's... Shower, yeah, great question. So about 5 minutes, yeah. Yeah, I have been known to leave my kids in the bath a bit longer if I need a little bit more time to cook dinner or something. But yeah, usually about 5 minutes if you can, and not too warm. I've never had a thermometer to test the bath water. I just say the cooler side of warm. Yeah, use some common sense and let's go cooler side of warm. If you put your hand in or your elbow in, it's nice and cosy, it's too warm. So these are some beautiful families who I've seen and this is why I just love seeing eczema in children, because the amount of thank you notes and thank you for saving my marriage and all sorts, these families are just so grateful with the most simple treatment and plenty of kind of support and education. They do great with the right education and the right treatment. They really do, so over 90% do really well. There's just a handful of children who are quite, tricky. So you've got these tired parents, they're sleep deprived, you've got this restless baby. I don't know about you, but in my clinic I see these children with eczema, they're just restless. I don't know if they're not always irritable, but they're just a bit restless. They just don't look comfortable and settled. And then usually within 24, 48 hours of using a topical steroid plus or minus wet dressings, they just, clear so quickly and are just different children. And temperament is not only clear skin, but temperament is a big and noticeable difference for these children. So this is a lovely baby who was day 0 and day 1. I've just prescribed Advantin fatty ointment once daily after the bath and wet dressings for 20 minutes. And this is the results after only 1 application. And this baby here had really impressive eczema, widespread eczema, about 80% of body surface area covered, and within 5 days was almost clear, not quite. So I just said continue with the Advantin once daily until the skin feels smooth, and then we'll talk about weaning shortly. So most of these babies do really, really well with some good daily bath or a daily bath or shower, followed by moisturiser and use of an appropriate topical steroid. Common triggers, so really helpful to, we've already talked about that anything that activates the immune system can flare eczema. So really helpful for parents to know that, because often they'll blame themselves. They'll think, oh gosh, do I need to change washing powders? Was it grandma's dog? Was it the cat? Was it whatever? But in actual fact, in many cases, it's just that we're not managing the eczema properly. But it is helpful. There are some triggers that we can avoid, and there are some triggers like viral illnesses and vaccinations that we can't. So we're not saying don't vaccinate. We definitely want these children vaccinated, but it's just to be mindful to remind them that anything that activates the immune system can flare the eczema. Heat is one of the most common triggers in eczema. So often the bath's too hot, they come in rugged up, they've got a singlet, a onesie, they go to sleep in a 2.5 tog sleeping bag. So even children with eczema, even though they're young babies, those babies with eczema, they tend to be hot. So just always, they do not need a 2.5 tog sleeping bag in addition to all those other things we talked about. And there is no right or wrong. If you've got an old house like me with lots of gaps between the floorboards, it might be cooler than, a new build that's not as cold. So I try and not be too prescriptive, but just remind families not to overheat their babies. Just avoid or just be very careful of heaters in bedrooms. If you live in a very cold house, or if the family lives in a cold house, sure, put the heater on for a few hours to warm the rooms up, but don't have it on, full heat overnight. Saliva and teething, that's very common. Often they'll get this contact irritation from the saliva. It's a real contact irritant. So using a greasy barrier around the mouth throughout the day can help. And also if teething, if foods cause some contact irritation, you can use a greasy barrier as well. So things like Dermese ointment, QV barrier cream, Ken-K zinc and castor oil creams, a nice cheap one from the pharmacy. Any of them are really great barrier creams, and they're also really good for nappy rash. Seasonal change, eczema's often worse in winter, not always though, and that cool, dry air. So that's why it can be really tricky to know how many, the layers of clothes and heating bedrooms, etc. Things like sand and grass and rough seams on clothing can all be irritating for these children. So if you've got a child who goes to the park and they're really easily irritated by sand and grass, things like that, you can wear longer, long pants, or you can wash their feet off when they come home, whatever the issue might be. But I find that it's less of a problem if their eczema's well controlled. If you've got this grumbling eczema, they've always got some eczema somewhere, then they're the children who tend to come home like a bit of a bushfire. If you go to the park or the beach with grumbling eczema, then they're often likely to come back quite itchy and irritated. So that's why we are very fussy in eczema clinic, and we want to aim for perfection at all times. No eczema's okay, so we aim for clear skin and we don't stop till we get there. So we've talked about topical steroids or flare control creams, and they are very, very safe when they're used properly, and helping parents understand that we don't want to use them every day for weeks and months. The idea is to use them like we do with a helicopter waterbombing the fire. And then they tend to be really concordant with treatment because they understand, they're like, oh, okay, so you don't want me to use this thing every day for the next 6 months. No, we don't. We want you to use it every single time there's a flare, because the skin's got very good memory T cells. So the eczema remembers to come back. So that's why they get really disheartened, because you get them clear really quickly and then they might have a cold 2 weeks later and then eczema comes back. So it's like, that's okay, you've got this, you just need to reapply your treatment as soon that evening after the bath. You reapply the Advantin or whatever they've been prescribed and use it every day till the skin feels smooth. And by doing that, like, every time the eczema comes, you're shutting it down, and for most children the eczema will go into remission. So really important to remind families, don't wait till the eczema gets really bad and then treat your eczema. Treat it as soon as you feel a little bit of rough skin or see a little bit of mild eczema. That's the time that you should be putting out the fire, not waiting till it's really bad. Now, there is not much eczema that you won't fix with these topical steroids. So our first line go-to in a baby with mild eczema would be Advantin fatty ointment. We would use that once daily to all eczema areas until the skin felt smooth. Then if we needed something a little bit stronger, we would use Momedit, so we would keep the Advantin fatty ointment for the face, and then we would stick with, then we would move to something like Mometasone furoate, 0.1%, which is either Novazone, Elicon or Zadamil, and that'll get most eczema on the body. But then if you've got, some of these beautiful children with skin of colour, or who have got lots of lichenified or discoid eczema, or hand and feet eczema, are more likely to need the next step up, which is the betamethasone dipropionate 0.05% ointment. And we typically, for most children with eczema, prescribe ointments rather than creams, because the ointments don't contain preservatives and they're more moisturising, more effective, work better. As I said, don't tend to cause any stinging or irritation, and more likely to clear the eczema quicker. So our dermatologists do typically like the ointments. We sometimes will prescribe a cream if we've got a teenager or someone who's more prone to folliculitis. We'll prescribe a cream, and then we'll typically prescribe a lotion for the scalp. So, yep, there is not much eczema. If only people followed this, I'd probably be out of a job. Yeah, they work really well. So we've already touched a bit on this. I won't talk too much about it, but don't be frightened to use a more potent steroid on the body or on a troublesome area like hands and feet, or nipple eczema. Nipple eczema, often you need to go use a potent steroid because that's really stubborn. We've talked about applying plenty to all eczema-affected areas, including areas of broken skin, every day till the skin feels smooth. And really important to promote or to really advocate for your families. When they go to the person who's prescribing the topical steroid, they need more than one tube, because you cannot clear widespread eczema with one tube very effectively. And one of our dermatologists, so they can get the topical steroids on the authority script via the PBS, the Pharmaceutical Benefit Scheme, and it's much cheaper. So just a little helpful guide is that if you've got a 2-year-old child with most of their body covered with eczema, they're going to be using half a 15-gram tube per application. So you can see most of these families don't use, if someone comes in and says, in that history that we talked about, how much topical steroid have you, or how much Advantin have you used in the last month? And like, not really sure. So how many tubes, or how long does one tube last you? About 6 months. So you just know that they're not using enough. So then that helps. So that's why that history is really important. They might be on the right stuff, they just might not be using enough of it. So we put together these guidelines. This is just an example of some guidelines to help people, predominantly in primary care, but actually anyone. Could be a paediatrician, GP, nurse, doesn't matter, because it's all applicable. There's just a bit on this first page about the general measures, topical steroids, and this is an algorithm. If everybody followed this, I think our wait list and our referral number of referrals would reduce by half. That is on the website, yes. It is. You can just Google Perth Children's Hospital ED eczema and it will come up with that. So I find weaning of topical steroids, now not all dermatologists will recommend weaning, there's definitely variations in practice, but I find, so if you've got a baby with acute eczema, you can apply the topical steroid every day till the skin feels smooth and then stop. But if the family says, well, I did that, and within 2 days the eczema's all come back, then you know we haven't quite cleared the underlying inflammation. So we just need to keep going for another few days and then wean it off maybe every other day for a few days. So weaning can be, that history is really important about, you know, usually there are going to be two things. One is when you say what's worrying you, the parents will often say, oh, well, I can clear my baby's eczema, but within 2 days it just all comes back. So in that case, it means we haven't cleared the underlying inflammation. We need to keep going for another few days and wean it slowly. Or my child's eczema just doesn't go away, persisting eczema. So that's the clue to you're probably going to need a stronger steroid. But there was a really nice scoping review that talked about this twice weekly maintenance. So if you've got troublesome hot spots to elbow creases, behind the knee, etc., then using your topical steroid twice a week to those hot spots, regardless of whether there's any eczema there, for 3 months can really help put the eczema in remission to those spots. So we use the twice weekly maintenance a lot. Or, you know, it can also be called weekend therapy. Use it on Saturday, Sunday or Wednesday, Saturday, it doesn't matter, 2 times a week for 3 months, and it really, really helps. In terms of choosing moisturisers, there is no one right moisturiser. Does anyone have any favourites that their families tend to really like? Do you find they prefer creams, thick creams, ointments? Creams, yeah. Creams for a lot of children because they're fairly cosmetically acceptable, but then if they've got lots of scratch marks, they might prefer an ointment rather than a cream because the creams contain preservatives. We tend to avoid lotions for most children with eczema because they're too watery, they don't contain enough oil. The moisturising creams, as I said, are very good. They're very cosmetically acceptable. And you can actually, the samples that you've got, if you just open a tube of the cream and open a tube of the ointment and put one on each hand, it's really helpful to see the difference because there's quite a difference. And if you're just recommending use ointment all over your body for a 15-year-old, you can see it's really important to remember what you're actually asking a family to do because it's pretty greasy and not all children are going to want to use a greasy ointment. The important thing is that they need to find something that they're going to be able to apply once or twice a day over over years. The problem is we don't want these families applying a lotion and then having to take pots of moisturiser to school because we don't want them to be different. We want them to be normal, and that's for something, applying moisturiser and helping our families find the right one is really important so that they can just apply it once or twice a day because you're more likely to get good results than needing, in certain situations if it's, the environment's very dry, then they might need to use it more often. But for most children, they do really well applying moisturiser once or twice a day. And the important thing is just make sure you're using enough. For babies, they should be using 125 grams a week. For a child, 250 grams, and for older children and adults, 500 grams. So for most of us, including myself, who have children with eczema, we are probably not using enough. Wet dressings. Who knows how to do wet dressings or who feels comfortable showing families how to do wet dressings? Few people? Excellent. Because wet dressings can make a really big difference and often you don't need to do them for very long. For those of you who want to learn or want to know more about wet dressings, if you Google the nip allergies in the bub, or even you can Google nip bub website, how to do wet dressings and the videos. So they've got videos and infographics on how to do wet dressings. But typically I'll use, you can use something like tubey fast bandages, but I typically use a onesie. So we would recommend having a bath, hopping out of the bath, pat the skin dry, apply the topical steroid to all eczema areas. Now in some states they'll then apply moisturiser. But for us, we would typically just use a onesie in a bowl of warm water, squeeze it out, put it on, wrap them in a towel or a blanket or a princess wrap, whatever you like to call it. And then for 20 minutes, they can have a feed, cuddles, read a book. And then 20 minutes later, you'd take the wet dressing off, apply moisturiser, always really important to apply moisturiser after wet dressing, and then jammies on and they're ready for bed. So they work really well, very cost effective, don't cost anything, and they make a huge difference. And we would typically recommend wet dressings if the topical steroid's if they're a bit slow to respond to topical steroid after a couple of days, or if sleep's affected, I'll go straight to wet dressings and that night they'll sleep really well. Bleach baths we've already talked about how they are very helpful in reducing the staph load, and I do always ask families if they go swimming because so basically swimming is like having a bleach bath. So if families aren't very keen on bleach baths, then I say no problem. Have you got a local chlorinated swimming pool? Yes, great, go swimming once or twice a week because it acts like a bleach bath. It's a very similar concentration. So, but otherwise with bleach baths, again, you can look at in terms of recipes, you can look at the NIP Allergies in the Bub website. It's got infographics and videos on how to perform bleach baths. And we would typically recommend them 2 times a week for 3 months, and they work very, very well. So this would be a typical day in eczema clinic. So we've got some infection, we've got lots of lichenification and lots of post-inflammatory either hypo or hyperpigmentation, and I'll show you that in some of the pictures here. So dark skin can often trip people up with eczema. Eczema severity is often underestimated, and so these children are often not treated adequately. Redness is very tricky to pick up. Like I said, often, it'll be these dark dry patches, sometimes the grey, as you can see in this child here. So we're really used to looking at erythema in eczema, but for skin of colour, you're not going to be looking for redness. You're going to be looking for, as I said, so usually grey or sometimes violaceous. So you can see this gorgeous girl. She's got lots of eczema around her eyes and she's got some on her tummy and quite extensive eczema on the legs, and sadly a lot of people will miss that. So these children typically have thickened hyperkeratotic plaques, which many clinicians often mistake as dry skin, so it's not treated. And you can see she's got some follicular eczema on her tummy and lots of active eczema and lots of post-inflammatory hyperpigmentation. I won't go too much into this, but DermNet has some great information on ethnic or cultural dermatology. So let's just move into a few case studies now. This is a 3-month boy. So some of these case studies are typical things that we would see every day in our hospital clinics and in our community clinics. So we've got a 3-month-old baby. Eczema started at 6 weeks of age, and he's predominantly a breastfed baby. Who would like to suggest what we should do with this baby? Does someone want to have a go at the answer? Did I hear treat the eczema? Yep, that's exactly right. So a lot of these families will be told, as I said, to exclude lots of different foods, but really important, leave the food alone, because if there's nothing in your clinical history to suggest that there's an index reaction from a particular food, treat the skin first. Yep, that's exactly right. So treat the eczema, keep telling mum to eat what she's eating, and baby's breastfed, so not eating yet. Yep, good, okay. So this baby, they've come to your clinic, you've cleared the eczema beautifully, and now the parents want to start solids. So what would you tell them to do? We've got a 4-month-old baby, eczema's well controlled, ready to start solids. Yep, exactly. We don't want to delay any of the common food allergens. We want to start solids. You guys are great. And if anyone's got any, wants to read further or wants to direct families to the ASCIA guidelines regarding infant feeding and allergy prevention, there's some great guidelines there. I don't know about you, but I get asked this question quite a lot in clinic. So let's say dad has a peanut allergy and they're wanting to know, the parents are wondering whether they should introduce peanut to this baby, and the answer is yes, definitely. So we've just got to help them find a way that's safe for that to happen. So do they do it when dad's at work, or do they go to auntie's house, or whatever it might be? But really important that we don't exclude that particular food from this baby's diet. So we've got a 7-month-old boy, and he's eating, so basically in that history that you took, when you asked about is there anything that makes the eczema worse, after eating tomatoes and strawberries, this is what happens. And parents want to know, is this a food allergy? What should we tell them?
Hands up, yes. Hands up, no.
Yep, okay, great. So what is it? And what would you tell the parents? Contact irritation, yep, from the acidic foods, yep, can happen with tomatoes, bolognese, berries, yep, and to use a barrier, one of the barrier creams that we talked about, around the mouth before and after meals and throughout the day if there's teething as well. Yep, excellent. So we'll just skip through to diet now, just talking about a little bit about diet and eczema. So I think the important thing, a lot of families, we run a combined eczema allergy clinic for the younger children who have got eczema plus or minus food allergy or food allergy concerns from parents. And a lot of their worry is that because my baby's got eczema means they must have food allergy. But we need to help them understand that actually it doesn't mean they've got food allergy, it's just that it's not causing the food allergy, it's just that in children with eczema, a lot of them, they've got a higher rate of developing food allergy. So, and, you know, with that contact irritation, it's really helpful to help parents understand about, well, what is an allergic reaction? So in your history, what I'd be worried about is if a child eats egg, for example, and develops hives, facial swelling, vomiting, whatever it might be, within 15 minutes of eating that food, then yes, that's certainly suspicious of an IgE-mediated reaction. If they're just getting a bit of contact reaction, then we've already addressed what we would need to do with that. And the other thing is sometimes a child might just develop one hive and then you think, oh, what's that? And that's actually not that uncommon in these children. They've got very sensitive skin. So often what I'll do is clear their skin, use a barrier cream and try again. I wouldn't be excited enough to stop the food in that case. And the other thing to mention here is that you know, if their eczema is flaring sometime later, like more of a delayed reaction, a food diary can be really helpful. Because when you've got poorly controlled eczema, like so many of these children do, it's really hard to know what's causing what. When they've always got grumbling eczema on their body somewhere, it's hard to know, well, was it that it was a bit hot last night or a bit cold last night, so we overheated the baby, we had the heater on all night, or actually we did go to the park with some relatives 2 days ago, it could have been that. And poor parents go around in circles. It's very worrying for them. So that's why we aim for clear skin, and then it's much easier to know, oh gosh, well, every time he has egg, 4 hours later he develops a widespread flare, so we can work with that. The other thing is that very commonly these children with eczema, they'll, you know, when the families are introducing the common food allergens, the eczema might flare a bit, or in fact any foods. But that's not a good enough medical reason for us to exclude the food from their diet. So what we do is we would manage the eczema really well, keep the food in the diet in very small amounts, it might even be half a teaspoon 3 times a week, and then just gradually increase and titrate to threshold. So rather than take the food out of the diet just because it's flaring the eczema, we would rather keep the food in the diet, because if you take the food out, there is no way you can be promoting oral tolerance. So if you're keeping a little bit of, you know, that food in the diet in small amounts, manage the eczema well, and then just gradually increase the amounts as you can, that's more likely to help them promote tolerance. So we don't want to, unless there's a clear history of food causing allergic symptoms, we don't want to exclude any foods, and we want to introduce all the common food allergens in the first year of life, particularly egg and peanut early. With allergy testing, a lot of our families will ask us, often they get really disappointed when they see me in eczema clinic on a Monday morning when they've been referred to our hospital immunology clinic. So many of our referrals are, please see Jack for eczema and suspected food causing the problem, but there's no history, and we're asked to do skin prick testing. So often what will happen is the immunology doctors will redirect the referral through to dermatology, we'll sort the eczema out, and then if there are still concerns, then we'll look at bringing them into our combined clinic and doing some allergy testing. But we only do very targeted allergy testing, because if you do skin prick testing and it says that this child is sensitised to egg, doesn't necessarily, just because you're sensitised, and there's a lot of false positives for these children with eczema, doesn't necessarily mean they're allergic. So you could unnecessarily exclude that food. So that's why we get more excited by, if we eat the food and there's clinical reaction, then we'll look at skin prick testing and excluding the food, etc. So what I thought is, so these are, we've just included a few case studies to finish off before Darren's going to be talking about some really helpful education information. These are basically referrals that are sent to our tertiary hospital eczema clinic, and so this is what I would typically see you know, in my clinical practice on a day-to-day basis. So I don't know, Darren, do you think it's worth getting people into groups, or probably not? Yeah. So what I will do is, how about if I just give you 1 minute to look at the case and turn around or work in just small groups and just have a chat amongst yourselves about what you think you'd do and what other information you'd like to know about this boy. 14-month-old boy has been referred to our NP eczema clinic for eczema support with regards to optimising his eczema management. So this will just be like a really common referral. He's currently using Novazone cream. So we said that Novazone is a moderately potent steroid, and he's 14 months old, and he's applying it to the worst affected areas. He's very itchy. He's got some eczema on his face, flexures, some scratch marks and some lichenification. So just before I go to the next slide, who wants to put up their hand and just let me know what other information you'd like to ask the parents about, or what you think we should do? Any suggestions? Yeah. Yeah, wet wraps would be really good. He's really itchy. Excellent. Yep, so that's what we did. We used some wet wraps. And what was the first thing you said about the cream? Yes, we could do that. He's using a cream. So we talked about using maybe an ointment would be good. So yep, that's exactly what I did. This child came through to my telephone clinic, because they usually will come through to my telephone clinic and then we'll work out what we need to do with them. So yes, I prescribed mometasone ointment for the body. And what would we have done with those lichenified areas to the ankles? Yep, so moisturise, and so I did also prescribe something more potent for the lichenified areas to just get it clear quickly. So we used the mometasone ointment to the body. We used some Elufrat, so some betamethasone dipropionate, something a bit more potent for the ankles. We talked about, are you using moisturisers, and talked about the general measures, as you all mentioned, so that's good. Excellent. And yes, we did use some wet dressings. We gave them a written treatment plan. I emailed some helpful eczema resources to the family. I emailed the script to the local pharmacy. Parents went and picked it up that day. They came back to clinic in a month's time, and they were doing a beautiful job and were discharged, and I gave them my contact details. So well done. You guys can all come and work with me in clinic. And so this is the treatment plan, one of the treatment plans that are available that you might find helpful, or you might have your own treatment plan in the clinic in which you work. But certainly having a follow-up, a timely follow-up, not 6 months later or 3 months later, but a close follow-up and a written treatment plan is really helpful for these families. We did a parent survey, an audit if you like, asking families what was helpful about the service when we set it up, or even we still ask these families now, what was helpful, what could we do better? And they love the fact that they got something in writing with our contact details on the back and the timely follow-up. Great. Any comments about that case before we go to the next one? Okay, so this is a 7-year-old girl who's referred by her GP for persistent dermatitis and severe eczema, not improving with topical applications. So this is what the referral said. She's got widespread eczema, very itchy, can't sleep properly, that parents have stopped swimming lessons because they are worried that this might be making the eczema worse, and they're using the Advantin fatty ointment sparingly, and have used 1 tube in a month. So in your groups, just have a little think about what we should do for this girl. Okay, so what do you think we should do with this girl? What should we ask this girl and ask her parents? What should we suggest they do? Yes, exactly. Use your steroid more. Use it liberally, not sparingly. Excellent. She's 7. She's got widespread eczema, so using Advantin fatty ointment, which is something we would use on a 4-month-old, we could probably go use the Advantin for the face and go something stronger for the body so that we clear it quicker. Yep, get her back to swimming, get her back to school, get her back sleeping properly. Yep.
And moisturise before she goes swimming as well.
Yes, moisturise before and after swimming. Because if someone's got lots of scratch marks, that when they go swimming, that can sting. So often, if we've got a family like this, often what we'll do is say, okay, this week, let's just tidy up the eczema. And then next week, when the eczema's clear, let's get you back to swimming. Yeah. Because sometimes they do have a fear of, even sometimes when they have a bath, it stings. So in that case, I'll just put some topical treatment on, do a wet dressing, and within a couple of days, you've almost cleared the eczema so that they can get back in the bath without it stinging. Good. Okay, now I'm going to just move along in the interest of time. What do you think this might be? This is someone who came to my eczema clinic after we'd started some bleach baths. Any suggestions? Was the bleach too strong? Yep, that's a great thing to ask. So this family were doing everything we'd asked them to do. And actually they'd done only 2 or 3 bleach baths when they started to notice some skin peeling. Was the water too hot? Yep, great thing to ask. Nope, the water was perfect. Were they moisturising? Yes, they were moisturising. No, but good thought. Yep. So in actual fact, this family were using QV flare-up bath oil. When we did the telephone review, they said they were using QV bath oil. When they came in and we saw this, we thought this just is not matching up. We do bleach baths all the time. This family was just adamant they were using the right instruction, the right dilution. And so then we delved further and sure enough, this family was using the QV flare-up bath oil, which contains benzalkonium chloride. So if you want to learn more about that, we do see a lot of contact irritant dermatitis from it. And if you Google DermNet, benzalkonium chloride, it will show you the other ingredients they've got in it. But we have seen it a fair bit with COVID, with the Dettol laundry rinse, yes, and the Caniston laundry rinse as well. So just be very careful if you ever see someone like this, just make sure they're not using something with the benzalkonium chloride in it. They were just using it, so they weren't combining it together, but they were doing their bleach baths 2 times a week. So they'd only done 2 or 3, and then the QV flare. It just happened to coincide with the time that they'd started the bleach baths. So tripped me up, this one. So in the QV flare-up bath oil, the QV flare-up oil contains benzalkonium chloride, and that's what causes almost like skin burning and peeling. Yeah, so it's the benzalkonium chloride in the flare-up oil, not the plain QV bath oil. The plain QV bath oil is what you want to aim for. Yeah, so just be careful. Sometimes the QV flare-up or anything that contains the benzalkonium chloride can cause this. Yeah. No, it's not from using too much benzalkonium chloride. It's just that the benzalkonium chloride in some children can cause this irritation. Yeah, no, it wasn't that they used too much. It's just this is what can happen. Yeah. The Dettol rinse. So usually you'll notice it usually won't be too delayed. Yeah, usually it'll be we've changed washing detergents, and this is what we've noticed. Yeah. Yes, that resolved. It resolved quite nicely. I followed them up weekly to reassure the family, because they were a lovely family. And initially they were thinking, "Are you sure it's not the bleach bath?" So I brought them in. I said, it's not making sense. And his pattern of distribution wasn't making sense either, because if you actually look at him, he was lying down in the normal bleach bath, but he hasn't got any skin peeling to his upper arms or upper torso. So it wasn't really making sense for me. But I got the dermatologist to have a look just as a second opinion. Yeah. Yes. Anyone with the benzalkonium chloride, yeah. Benzalkonium chloride is an ingredient in some of these skin products, yeah, and that's why I've learnt so much looking at that DermNet. It's got a nice big page on it, and it's for infection. So, well, actually, it's actually promoted. The QV flare-up oil is promoted for these children who have a flare-up. Yeah, and also contains triclosan, so it's sort of promoted as an anti-infective, if you like, so to help settle down the staph on the skin. And of course, the results have been very promising in their studies, etc. But clinically, the dermatologists don't typically like it. That's right. Not all children do. Yeah, that's absolutely right. But a lot of children do. Yeah. Now, just in the last couple of minutes, I've just included these last couple of rashes before Darren comes up to talk, because these are very, very common things that are often referred to eczema clinic that don't improve with topical steroids. What do you think this is, and how do you think you'd describe it? Any suggestions? Viral's one. Any other suggestions? Keratosis pilaris? Yep. Spot on, you get the chocolate frog. Yep, so keratosis pilaris, and I've had lots of GPs who have done a great job, and I have so much admiration for them referring them in when what they've thought would work is not working. So often, they get these, it's basically like chicken, little bumpy rash on the backs of their upper arms, and often on the sides of the face in these young children and toddlers, and on their thighs as well. So, straight away when parents are telling you, it's almost textbook picture. And often, if they've got a bit of redness on the sides of the cheek and the backs of the upper arm too, it's called keratosis pilaris rubra, but that's why many people think it's the eczema. So if they're prescribing a moderately potent steroid that's not clearing that redness, then that's your giveaway. Remember that we talked about what else could it be? This is a situation where it's something else other than eczema. The thing is that a lot of children with eczema do have KP rubra. Molluscum, the last point is just to remind you that whenever children do have molluscum, because children with eczema commonly do have molluscum, it's really important to treat the molluscum dermatitis, because otherwise a lot of people are worried about putting the topical steroid over the lesion, but just put it on, settle down the inflammation so they don't scratch and spread the virus elsewhere. Yep, something we see commonly that is not treated that well. But often, the molluscum themselves, it's not a problem, but it's itching and spreading the virus that's the problem. So I'm just going to pass you over to Darren, and then after Darren's presented these few slides, happy to take any questions about what we've just talked about or anything to do with eczema.
Okay.
Just can flick it with that.
Oh, yeah, that one's... Okay, still awake? Good. And I'll make it... There won't be my usual patient education talk that goes on for a long time. It's the fact that we need to be looking at patient education through a different lens, because we give them all of this information, and often we don't necessarily go through the process of helping them turn it into the knowledge that they can use, because they've got to be, we're unpacking the box. And back on Gemma's case study, I didn't want to pipe up then, I thought I'll bring it up now, but back on the first case study was the fact that when you're unpacking the box, and Gemma does this as part of her tacit knowledge, so she wouldn't have even thought to say to you, oh, well, actually, I unpack the box, and then she'd be asking, how have you been putting those things on? What was the order of the steroid and the moisturiser? Because quite often they might have started off at the last visit and then they went to mother's group and someone did it the other way round. Okay? And sometimes the mother's group wins out over what the nurse practitioner or the doctor says, because it's on social media. So just some of those things of unpacking it. So providing the relevant information and the care plan, that's fine, that's all great. Listen to their story. But because of the fact that we're not curing it and we've got to help them to master it, we've got to then step them through all of the processes that they turn that information into knowledge. And you think back to your own school days and stuff, when they go, did all that stuff in the class, you had to go home and do some stuff and actually convert things and make that knowledge activated. And the nurse is the conduit in the process of you helping do it, and it's not going to happen in one consult. So we've got to help them to be confident and capable. Now, the demonstration and the explanation of things is really, really important. And I know a lot of people say, oh, the fingertip unit's all too hard to do it. But one of the things, if you'll get your ointment tube, and just pretend that's your steroid, and you actually do the fingertip unit with your tube on your finger, from your fingertip right down to the end. And remember that your steroid tube is actually a little bit wider than that. So do it on there, because otherwise you're not going to get you're actually not getting the impact of what I'm trying to say. because this blew me away the first time I did it, right? So does people know the fingertip unit covers how much of the adult hand? People know that? You've seen it 1,000 times, but it probably isn't stuck in. So put it on your finger. No, the ointment. Ointment. Well, I suppose a cream will work all right, but it's better to do the ointment. Then it covers the area of 2 adult hands. Now just gently rub that round on your palms, particularly if you've got the grease on, but there could be steroid cream as well. Don't rub it too much in. How thick is it? Is that as thick as your family's put their steroid on? Never. So this is the same as 1/4 of a Panadol when you've got a really bad headache. So this is why the eczema is not getting better. So even though they've been putting it on, yes, doing exactly as they say, we need to be checking that. And that simple thing, and I didn't used to do it because years ago a very wise dermatology nurse said to me, oh, look, that's all too hard, we've got such limited time, just say the shine. And I did that for ages. And then one day I did, I thought, oh my goodness me. And no patient has ever said, one, I think has said that this was as thick as they did this steroid. Now, buy paraffin, don't do it with a steroid on your own hand, obviously, or you will have problems doing it, 7 times a day. Because, they're the sort of moments that the pennies start to drop. And then asking what worked and what didn't work, because quite often you do the plan and then, the child won't put the wet wraps on after the second visit. So you can actually put those wet wraps on and then even spray the wet wraps with the warm spray water afterwards. Sometimes that works really well. Putting a little, Superman cape on the outside, all those sort of things. So, and seeing how it worked at the follow-up, and then the psychological support is also really important. Has anybody ever referred their patients to the 3 free sessions that the Eczema Support Australia has got? It used to be called Hands to Hold. There's an ongoing grant that Melanie Funk got to where they can get 3, self-refer, the nurse can refer, doctor can certainly refer, and a few of our allergists have even referred the adults that had eczema that needed this. And they get, I think it's a half-hour or 1-hour consult talking with the psychologist, and they can have 3 visits, and it's not one where you say, good, now I'll take you $1,000 and, here's a cause. Sometimes people only need to talk about things for, one consultation and just help to, unravel and settle down some of their anxieties. So we've got to be checking that the patient, with the process of the family education, is their head in the right head zone? Have they just found out the eczema can't be cured? Have they had bad information before, conflicting information? Most people have had that conflicting information. So we've got to make sure that they're in that right headspace. And then giving them the information pack and all that you give them, and explaining and demonstrating. So they've got to have, as Gemma said, the brick wall, explaining about the facts and why they have to be putting the different creams on, weaning the steroid. I always say that your own body makes steroid, but when the doctor gives you the steroid with the flare, that's to help you with the eczema. And your own steroid goes to sleep. And I used to say it packs its bags and go to Bali during COVID because there's no one on the beach. When they've got to used it until it's gone away, that's fine, but we've got to wake up your own steroid again so it remembers what to do instead of the steroid, instead of the help that it's been having. So that's why we've got to be weaning it down. And quite easily they say, I wouldn't want to come back from holiday either, So that gives them some, using those little analogies. And then, we've got to extend and refine that information. So when you get them back, how did this work? Did he like the grease? No, won't wear it to school because the kids tease him. You've got to be then working on other ways to be going through all of those things. As I said, demonstrating and showing what to do, getting them to practice how to do things. And just, giving one pamphlet about the wet wraps. Looking on the video is great. It means often you don't have to do the wet wraps in the clinic because you can't often have time to do those sort of things. And then if you go through those sort of processes, and then when you get them back, you might need this in 3 or 4 consults, and that you said, oh, great, how are we going to manage that in our limited clinic time because there's never any money for patient education within any of the clinics. You can be giving them little scenarios. So what happens if he gets his teething, and the eczema flares up, what are you going to do? And then step down the plan, and hopefully the parents will say, oh, well, I need to get my steroid cream out again and, use that for the days, that you say on the plan, et cetera, et cetera. And then that's the way that those things become part of their second knowledge, because what you're doing there when you're doing that is helping them use their cognitive learning principles. So it's the thinking part. We need the people to be thinking, reasoning and problem solving, and that's what you do every day in clinic. Within your clinical practice, it's how you learn all your nursing, etc., and acquired your clinical wisdom, etc., that guides your practice. But we actually need the patients and the families to be doing these things themselves, because that's how they manage at home. And that's what I spent the 5 or 6 years of my PhD, is getting the data out of the parents and the nurses as to how they were using these principles in practice. They were using them, but they weren't written down at all in the literature, etc. Breaking those information into little steps, creating a mental toolbox, and if they're not in a great head zone, you say, well, there's other things we've got to do, but we'll put these in the box for now, and we'll just do the steroids and the moisturisers at the moment. They might be so unresponsive to bleach baths, that you just think, right, we need that, but we'll just, come back next week and we'll have another chat. And once you've got them thinking, reasoning and problem solving, that they start to see those rewards about what they're doing, and they can explain to you in those scenarios, help you be able to do that. So there's actually a resource out now, and if you want some, there's some up here that explains what cognitive learning principles are. Now, the resource that the parents and the nurses come up with is not a prescriptive thing of you do A, B, C, D. It's a series of cues as to how you are, checking that they're in the right headspace, acquiring and integrating that knowledge, the factual, the explanation, the demonstrations, etc., revising and follow up, refine the techniques, etc. What have they forgotten, etc. And then with the using it, how did it work? And they will be starting to see those things that make it made an improvement, and then they're adapting care, and then the eczema becomes part of their daily life. The talk I did for the GPs yesterday that actually explained this much better, because I can't do it in 5 minutes, will be in the ADNA members' website. Okay, I haven't asked them to put it up yet, but they will. So you'll be able to go through that PowerPoint, which will explain this in a little bit more detail. And it's something that's based on the Dimensions of Learning framework that's been used out in education for 35 years, and it's how kids come out of school being able to think, reason and problem solve for their life. And I think we're going to need to pull this out of the archives again, because we've got a whole generation of kids that are forgetting how to think because everything's on the phone. So that's just thinking about things through a little bit of a different lens. Okay, so we're nearly at time, so...
And so then I think the last thing just to mention, thanks Darren, is some helpful eczema resources. Often when I'm writing the scripts and writing the treatment plans, I'll often get them to just watch a quick 5-minute video. So some of the ones that are helpful are the eczema videos on the Nip Allergies and the Bub website. For teens, you've got the 250K website, and also if you Google Fiona Stanley Hospital Clinical Immunology, scroll down the page and you'll see a 5-minute video called Operation Itch, and it's a 5-minute video, and that's really helpful. It shows a child getting out of the bath, patting the skin dry, applying the correct amount of topical steroid followed by moisturiser. And even when, as Darren says, even when I show families in clinic, their chins drop and say, oh my gosh, oh no wonder the eczema's not clearing. And so they go away and do the right thing, and most of them do really well. So I think it's just helping them understand, once they see the video or see you demonstrating in clinic, they've got it. But until you do that, they haven't quite got it, I find. So there are some helpful eczema resources. If anyone wants to contact us at any time about helping set up eczema clinics, eczema education, nurse practitioner clinics, you're so welcome. We're happy to share anything that I can help you with. Please don't hesitate to ask. We always love doing collaborative work, so if you're ever wanting to do multi-site paediatric eczema quality improvement things and research, you're very, very welcome. Just email me anytime. Shall I give you the answers to the questions? You probably haven't had a chance to do the post-test. Do you want 30 seconds to do the post-test, or do you want me to give you the answers? 30 seconds? Okay. How did your session go? Have your sessions finished? Oh. I can never finish early on eczema, that's the thing. I could talk about eczema for a week. So the answer to question 1 is what? Which one of the following statements is correct? Eczema is a chronic skin disorder. True. There's a strong link between eczema, food allergy, asthma and allergic rhinitis. Correct. And regular emollient use is important in the management of eczema. Yes? So D is the correct answer. Yep, well done. What's the number 2, what's the right answer? B, yep, excellent. Good. Number 3? D, yes, use moisturisers, plenty of them, to the whole body, not just the eczema-affected areas. Yep. How much moisturiser should we use? Question 4, for a 5-year-old child. A, yep. Oh, these guys are great. And number 5, last question, what's the answer? A, yes. You can all come and work with me. So great, yes, brilliant. Does anyone have any final questions before we close? Yes. Oh, with the wet dressings? Yes, so with the wet dressings, so we would apply the topical steroid, then some places do the moisturiser, some dermatologists prefer just to do the wet dressing. Yes, you do the wet dressing in warm water, squeeze it out, and you can do a wet beanie as well. If they've got scalp eczema, works beautifully. Get a cotton beanie, squeeze it out, put it on the head, and then get a dry layer, blanket, another onesie, towel, wrap them. Some places do it for an hour. We tend to do it for 20 minutes, whatever, 20 to 30 minutes. And then take the wet dressing off, and while the skin's still damp, then you apply moisturiser. That's right, yeah. Rather than waiting, because if you, with the water, you moisturiser before the wrapping, yes, some places do that. Our dermatologists worry about the increased risk of folliculitis and the added step for parents when it works just as well the other way. So I kind of, when we were developing the National Allergy Strategy resources and trying to keep all the states happy, that's why you'll see in some of them it says if your clinician suggests you use moisturiser, then you would apply moisturiser after the steroid. But yeah, steroid plus or minus moisturiser, wet dressing for 20, 30 minutes, take the wet dressing off, then apply moisturiser to the whole body. Has that answered your question?
Yeah. Open the discussions with your clinic. Like if you're doing different things, just open the discussions. It's not meaning you're doing it wrong. It's just there's different opinions with different clinicians, and it just opens the conversation. They may all say, well, no, we've done this. This has been successful. Here's, this review of this and that and the other. And then, you've had that open conversation, but you might find a family that the other way works better. So, and that means then that, there's a bit more out there with consensus. We never get, even with consensus, you're struggling. Yeah, because there's so many different opinions.
I've just got a couple of things to let you know. Before you all run away, we're hoping to get everybody together just minutes before the AGM so that the different states, people from the different states can huddle and discuss what we would like at the education days in our states. We're actually hoping to get representatives for each state this time, but also what you would like to learn, what speakers, whether you know speakers, could volunteer speakers or volunteer to speak, and the venues suggested, all those sorts of things. So just a quick huddle to get ideas so that the people that are running the education day in the States have helpers perhaps, and also definitely ideas that you are wanting. And lastly, I wanted to say thank you to Gemma and Darren for their excellent speech and talk and education. And we have these bottles. These are from Goodwill Wines. So whether you drink wine or not, it doesn't matter. The money was actually donated to the charity by the group is called Ganawira, which is the Young Aboriginal Mothers Program. It was actually done with the Catholic University, Australian Catholic Universities in partnership with Ganawira. So the speaker's gifts.
And for mental health and well-being.
Thank you. So thanks so much, everyone. I hope you found that helpful, and I hope that you've even just taken away one or two helpful, practical things that you can apply in your daily work, and just know that we're available anytime. Call or email if there's anything I can help you with regarding eczema in children. Thanks very much, everyone.